Good evening. Tonight we descend into a story that begins in an operating room in November 1941. A young woman lies on the table awake, straps securing her feet, while surgeons drill through the top of her skull on both sides. Her name is Rosemary Kennedy, and she is 23 years old. The doctors ask her to recite the Lord's Prayer, then to sing God Bless America, then to count backward. They are listening not for accuracy, but for the moment her words become incoherent. That is when they will know they have cut enough. That is when they will stop destroying her brain. When she can no longer form words, they withdraw their instruments. She will never speak clearly again, never walk without assistance, never live independently for the remaining 64 years of her life. The procedure was called a lobotomy, and Rosemary Kennedy was the sister of a future president of the United States. She was also just one of approximately 50,000 Americans who would undergo this operation over the following 2 decades, an operation in which doctors believed they could cure mental illness by severing connections in the human brain, an operation that would win a Nobel Prize, an operation that promised miracles and delivered devastation. The story of lobotomy is not simply a tale of medical malpractice or misguided science. It is the intersection of overcrowded asylums where hundreds of thousands lived without hope, desperate families searching for any solution, ambitious physicians competing for recognition, and a society that valued institutional control over human compassion. Within a single decade, the procedure spread from a small hospital in Lisbon to operating rooms across Europe and America. It was championed by prominent neurologists, performed on children as young as 4, and widely promoted as a breakthrough in psychiatric care. And then, almost as quickly as it appeared, it vanished from mainstream medicine, leaving behind a trail of damaged minds and shattered lives. To understand how this happened, we must first descend into the world of psychiatric care in the early 20th century. A world of massive stone institutions filled far beyond capacity, where patients spent entire lifetimes confined behind locked doors, where doctors possessed no effective treatments and watched helplessly as their wards filled with human suffering they could neither cure nor alleviate, where any intervention, no matter how radical or experimental, seemed preferable to the alternative of permanent institutionalization in what many called living death. The psychiatric hospital of 1930 bore little resemblance to the hopeful vision that had created such institutions a century earlier. The massive buildings that dotted the American landscape, often built on the outskirts of cities with their imposing Victorian architecture and sprawling grounds, had been constructed with therapeutic intentions. The theory of moral treatment that guided their design suggested that mentally ill patients, removed from the stresses of society and placed in peaceful, structured environments, might find their way back to sanity through rest, meaningful work, and gentle guidance. But by the time the Great Depression descended on America, those intentions had long since been buried under the sheer weight of human need. The asylums had become warehouses, not therapeutic retreats, but holding facilities for people society did not know how to help and could not afford to ignore. The numbers tell a part of the story. In 1903, there were approximately 150,000 patients in American psychiatric institutions. By 1938, that number had swelled to nearly 500,000. A single report from that year noted that psychiatric patients occupied 55% of all hospital beds in America. 1 bed for mental disease for every bed for all other diseases combined. By 1940, there were approximately 1 million patients confined in state and county psychiatric hospitals, and the population was growing at a rate of 80% per year. The institutions could not expand fast enough to accommodate them. Wards designed for 30 patients held 60. Dormitories built for comfortable sleeping arrangements became seas of beds, arranged so closely that one could barely walk between them. Privacy was not merely absent, but impossible. Dignity was a luxury these institutions could not afford. The Great Depression made everything worse. State funding for mental hospitals, never generous, was slashed as tax revenues dried up. Staff were laid off. Maintenance was deferred. Food budgets were cut to the bone. In some institutions, patients went hungry. In others, they froze in winter because there was no money for adequate heat. The reforms that had briefly flickered in the early 20th century, the attempts to implement therapeutic programs and humane treatment, withered in the face of economic catastrophe. What remained was custody. The primary function of these hospitals was no longer to cure or even to comfort, but simply to contain, to keep the mentally ill separated from the rest of society, to prevent them from becoming public nuisances or dangers, and to do so at the lowest possible cost. The staff who worked in these conditions were overwhelmed. A single attendant might be responsible for 50 or more patients during a shift. Doctors, when they made their rounds at all, could spend only minutes with each patient. There was no time for therapy, for careful observation, for the slow work of understanding individual minds. There was only the endless work of managing chaos, of preventing violence, of maintaining some semblance of order in institutions that had long since ceased to function as hospitals in any meaningful sense. And the patients themselves endured conditions that would later be compared to concentration camps. Many spent their days in idleness, sitting or lying on benches, staring at walls, their minds unoccupied, their bodies inactive. Those who became difficult were restrained. Straitjackets were common. So were leather cuffs that bound patients to beds or chairs for hours at a time. In the most difficult cases, patients were locked in isolation cells, small rooms with nothing but a mattress on the floor, where they might spend days or weeks alone. The justification was always safety. The patient's safety, the safety of others, the safety of the staff. But the reality was that physical restraint had become the primary tool for managing human beings whose suffering expressed itself in ways the institution could not tolerate. The patients came from all walks of life, though the poor were disproportionately represented. Once admitted, few ever left. The average stay in a psychiatric hospital in the 1930s was measured not in weeks or months, but in years and decades. Many patients lived out their entire adult lives within institutional walls, growing old in the same wards, where they had arrived as young men and women. They married, if they married at all, within the institution. They worked in institutional laundries and kitchens, in gardens and workshops. Unpaid labor, justified as therapeutic, but functioning primarily to keep the institution running. They died there, usually buried in unmarked graves on institution grounds, their names recorded in ledgers, but commemorated nowhere else. For the physicians who worked in these hospitals, the situation bred a particular kind of despair. These were often dedicated men and women who had entered psychiatry, hoping to heal minds, to unlock the mysteries of human consciousness, to help the suffering. Instead, they found themselves administrators of custody, powerless to offer anything approaching cure. The medical literature of the period is filled with their frustration. They described it as therapeutic impotence. That phrase appears again and again in journals and conference proceedings. Therapeutic impotence. The recognition that despite all their training, all their knowledge, they had nothing to offer. The treatments that did exist were crude and largely ineffective. The most common intervention was simply sedation. Patients received barbiturates, bromides, paraldehyde, drugs that suppressed the nervous system and induced sleep or stupor. These medications did not cure anything. They did not even reliably reduce symptoms. What they did was make patients quieter, less demanding, easier to manage in overcrowded wards. They were chemical restraints, nothing more. For agitated patients, there was hydrotherapy. This involved immersing patients in baths of hot or cold water for extended periods, sometimes for hours. The theory was that the shock to the system might jar the mind back toward normal function. The reality was that it was simply another way of occupying and exhausting patients, of using their body's responses to temperature to induce a kind of temporary docility. Some institutions had special hydrotherapy suites, with tubs equipped to keep patients submerged, only their heads above water, wrapped in wet sheets that gradually cooled. Patients described it as torture. Doctors defended it as treatment. And then there were the shock therapies, the interventions that emerged in the 1930s and represented what many psychiatrists hoped might be a breakthrough. These began with insulin shock therapy, developed by Austrian psychiatrist Manfred Sakel in 1933. The procedure involved injecting patients with large doses of insulin, enough to drop their blood sugar to dangerous levels and induce a hypoglycemic coma. The patient would convulse, lose consciousness, and remain in this state for hours before being revived with glucose. The theory was that the shock to the system might somehow reset the brain, might break the patterns of pathological thought that characterized schizophrenia and other psychoses. It did not work, or rather, it worked unpredictably and at great risk. Some patients seemed to improve after insulin shock therapy. Many showed no change. Some died from complications of the procedure itself, from the dangerous metabolic stress it placed on the body. But desperate institutions embraced it anyway, because it was something. It was active intervention in place of passive custody, a procedure that at least suggested medical progress was being made. Metrazole shock therapy followed shortly after, introduced by Hungarian neurologist Ladislas von Meduna in 1934. Meduna had observed that epileptic patients rarely developed schizophrenia and concluded that induced seizures might prevent or cure psychosis. He experimented with various chemicals before settling on metrazole, a synthetic drug that, when injected, triggered violent convulsions. Patients described the experience as terrifying. The moment between injection and seizure was filled with an overwhelming sense of impending death, a terror so profound that some refused further treatments even when institutional authorities insisted. The seizures themselves were powerful enough to break bones. Patients fractured their spines, their limbs, their jaws from the force of their own convulsing muscles. And again, the therapeutic benefit was questionable at best. Then came electroconvulsive therapy in 1938, developed by Italian psychiatrists Ugo Cerletti and Lucio Bini. This refined the concept of induced seizures by using electrical current passed through the brain rather than chemicals. It was slightly safer than metrazole, though still brutal by modern standards. Patients were often treated without anesthesia or muscle relaxants in those early years, meaning they experienced the full force of electrically induced seizures. Memory loss was common. confusion, disorientation, headaches followed treatments. But electroconvulsive therapy did seem to help some patients with severe depression, and it was cheaper and easier to administer than insulin therapy. It spread rapidly through psychiatric hospitals. Yet even these interventions, radical as they were, offered no cure. They managed symptoms in some cases, offered temporary relief in others, and failed entirely in many more. Schizophrenic patients, who made up the largest portion of long-term institutionalized individuals, saw particularly poor results. They might be shocked or insulin comatose dozens of times without any lasting improvement. They would return to their wards and resume their previous symptoms, their previous behaviors, their previous suffering. The psychiatric profession faced a crisis of credibility. Psychiatry in the early 20th century was struggling to establish itself as a legitimate medical specialty, equal to surgery or internal medicine. But how could it claim equal status when it could not cure, could barely even treat the conditions it purported to address? Other medical fields were experiencing dramatic advances. Antibiotics were on the horizon. Surgical techniques were becoming more sophisticated. Cancer research was progressing, but psychiatry remained mired in methods that seemed to belong to an earlier, darker age of medicine. This was the landscape that greeted António Egas Moniz when he attended the Second International Neurological Congress in London in the summer of 1935. Moniz was already 61 years old, already famous in neurological circles for his development of cerebral angiography, a technique for visualizing blood vessels in the brain using X-rays and radioactive tracers. It was work worthy of a Nobel Prize, many thought, though the prize had not come. Moniz had reason to seek another achievement, another innovation that might secure his place in medical history. At the London conference, Moniz attended a presentation by two American researchers, John Fulton and Carlyle Jacobson from Yale University's primate laboratory. They described experiments on two chimpanzees named Becky and Lucy. The chimps had been taught to complete various tasks requiring memory and problem solving. They had also developed distinct personalities. Becky, in particular, was described as highly emotional. When she made mistakes in testing, she would become agitated, sometimes violently so, screaming and thrashing in her cage. Then Fulton and Jacobson performed frontal lobotomies on both animals, surgically removing portions of their frontal lobes. The results were striking. Both chimps could still perform many of their learned tasks, suggesting their intelligence had not been catastrophically damaged, but their personalities had changed dramatically. Becky, the agitated chimp, became calm. She could now make mistakes without becoming upset. She seemed, the researchers reported, indifferent to outcomes that had previously distressed her. Moniz listened to this presentation with growing interest. If surgical damage to the frontal lobes could calm an agitated chimpanzee without destroying its basic cognitive function, what might similar surgery do for agitated humans? For patients suffering from uncontrollable anxiety, from obsessive thoughts that circled endlessly in their minds, from emotional storms that made their lives and the lives of those around them unbearable. The idea was not entirely new. A few surgeons had experimented with brain operations for psychiatric conditions in the late 19th and early 20th centuries. Swiss psychiatrist Gottlieb Burckhardt had removed portions of the cerebral cortex from 6 patients in the 1880s, with mixed and mostly poor results. Russian neurosurgeon Ludwig Pusep had performed similar operations in 1910. But these experiments had not gained traction, had been regarded as too risky, too experimental, too much like mutilation. But Moniz was convinced that the field had advanced, that knowledge of brain function had progressed sufficiently to try again. And the situation in psychiatric hospitals had become so desperate that radical interventions seemed justified. What was the harm in trying when the alternative was lifelong institutionalization? What did patients in back wards, patients who had been there for decades without improvement, have to lose? This was the reasoning that led Moniz back to Lisbon with a plan. He would develop a surgical procedure that targeted the frontal lobes, that severed the white matter connections between the frontal cortex and other brain regions, particularly the thalamus. The theory, as Moniz developed it, was that mental illness involved fixed pathological patterns of thought, circuits in the brain that had become stuck in destructive loops. By cutting these circuits, by forcing the brain to form new pathways, he might break patients free from their obsessions, their anxieties, their delusional beliefs. It was theory built on theory, speculation stacked upon assumption. There was no real evidence that mental illness worked this way, that thoughts were simply neural pathways that could be rerouted through surgery. But the desperation was real, the suffering was real, and Moniz believed that action, even risky action, was better than the paralysis of therapeutic impotence. On November 12, 1935, in a hospital in Lisbon, Moniz performed what would become the first modern lobotomy. The patient was a 63-year-old woman who had suffered from mental illness for many years. Moniz did not perform the surgery himself. He suffered from gout, which made his hands too painful and unreliable for surgical work. Instead, he directed his colleague, neurosurgeon Pedro Almeida Lima, through the procedure. Lima drilled 2 holes in the top of the woman's skull, one on each side of her head. Through these holes, they injected pure ethyl alcohol directly into the frontal lobes. The alcohol destroyed brain tissue, killing neurons and severing connections. It was a crude method, imprecise, impossible to control exactly how much damage was being done or exactly where, but it was a beginning. Over the following weeks, Moniz and Lima repeated the procedure on 6 more patients, gradually increasing the amount of alcohol injected. Then, on December 27, 1935, they modified their approach. Instead of injecting alcohol, Lima used a surgical instrument, a leucotomy of Moniz's design, to cut through the white matter of the frontal lobes. This is considered the first true leucotomy, the first deliberate surgical severing of frontal lobe connections. Moniz reported the results enthusiastically. Of his first 20 patients, he claimed that 7 had recovered, 7 had improved, and 6 showed no change. These were remarkable numbers, if accurate, for procedures performed on patients who had been considered hopeless. But the reports were based on short-term observations, sometimes only weeks or months after surgery. There was no long-term follow-up, no careful documentation of side effects, no controlled comparison with untreated patients. Still, Moniz published his findings in 1936, and they attracted immediate international attention. Here, finally, was something new, a physical intervention for mental illness that claimed actual cures, not just symptom management, a surgical procedure that prestigious neurologist had performed and endorsed. The psychiatric world, desperate for any breakthrough, seized upon it. The news of Moniz's leucotomy spread through medical journals and conferences with remarkable speed. Within months of his 1936 publication, psychiatrists and neurologists across Europe and America were discussing the procedure, debating its merits, and considering whether to attempt it themselves. For a profession that had spent decades watching patients deteriorate without being able to offer meaningful help, the promise of a surgical cure was intoxicating. But it was in the United States that the procedure would find its most enthusiastic champion and undergo its most dramatic transformation. Walter Jackson Freeman was a man of considerable ambition and showmanship, qualities that would prove both essential to lobotomy's spread and ultimately central to its tragic legacy. Born in 1895 to a prominent Philadelphia medical family, his grandfather was the renowned surgeon William Skene. Freeman had entered neurology with the confidence of someone born to the profession. By 1936, he was chairman of the neurology department at George Washington University and a well-known figure in Washington medical circles. Freeman possessed a personality that blended scientific curiosity with theatrical flair. He was not content to be merely a competent physician. He wanted to be a pioneer, a revolutionary, someone whose name would be remembered alongside the great innovators of medical history. When he read Moniz's reports on leucotomy, he recognized an opportunity. Here was a procedure that was genuinely new, that addressed the most intractable problems in medicine, and that almost no one in America had yet attempted. If he could master it, improve it, promote it, he might secure the fame he craved. There was one significant obstacle. Freeman was a neurologist, not a surgeon. He had never been trained to operate, had never developed the manual skills required for delicate brain surgery. So he did what ambitious men often do when they lack a necessary skill. He found a partner who possessed it. James Winston Watts was a neurosurgeon, meticulous and careful, where Freeman was bold and improvisational. The two men made an unlikely partnership, but in 1936, they agreed to work together to bring Moniz's procedure to America. On September 14, 1936, at George Washington University Hospital, Freeman directed Watts through the first prefrontal lobotomy performed in the United States. The patient was a 63-year-old housewife named Alice Hood Hammett from Topeka, Kansas. She had been suffering from severe agitation, depression, anxiety, and insomnia. Her family had tried everything conventional medicine could offer, and nothing had helped. Now they were willing to try something experimental, something that involved opening their wife and mother's skull and cutting into her brain. Watts drilled holes in her skull and inserted a surgical instrument into her frontal lobes, severing white matter connections according to the technique Moniz had described. The surgery took several hours. When it was complete, Mrs. Hammett was moved to recovery. In the days that followed, Freeman watched her carefully, documenting every change in her behavior, every word she spoke, every sign that might indicate success or failure. He declared it a success. Mrs. Hammett was calmer, he reported. Her agitation had decreased. Her family was pleased. Within 2 months, Freeman and Watts had performed 20 more lobotomies. The pace was extraordinary, driven by Freeman's enthusiasm and the steady stream of desperate families willing to try anything. These were not carefully selected research subjects. These were people in crisis, people who had exhausted conventional options, people for whom institutional commitment seemed the only alternative. Freeman kept meticulous records of these early cases, though his definition of success would later be questioned. He categorized outcomes as improved, unchanged, or worse. By his accounting, the results were encouraging. Many patients showed reduced anxiety and agitation. Some returned to relatively normal lives. But Freeman's follow-up was often brief, his assessments optimistic, his documentation of complications incomplete. He wanted the procedure to work, needed it to work for his own ambitions, and that desire colored his observations. By 1942, Freeman and Watts had performed over 200 lobotomies. They had also refined the procedure, developing what became known as the Freeman-Watts standard prefrontal lobotomy. This involved a more extensive operation than Moniz's original technique, with larger incisions and more complete severing of frontal lobe connections. They published their results in medical journals and in a book titled Psychosurgery, presenting their work as a major advance in psychiatric treatment. The medical establishment's response was mixed. Some neurologists and psychiatrists praised the innovation, saw it as exactly the kind of bold intervention medicine needed. Others were deeply skeptical. The neurosurgical community, in particular, raised concerns. Brain surgery was a delicate specialty that required years of training. The idea of destroying healthy brain tissue to treat psychological symptoms struck many surgeons as reckless. And the lack of rigorous controlled studies, the absence of long-term follow-up data, the reliance on subjective assessments of improvement, all of this troubled those who valued scientific rigor. But Freeman was not primarily interested in convincing the medical establishment. He understood that physicians were conservative, that they would demand evidence and controlled trials and peer review before accepting something as radical as lobotomy. That process would take years, perhaps decades. Freeman did not want to wait, so he took his case directly to the public. He courted journalists, gave interviews to newspapers and magazines, appeared on radio programs. He described lobotomy in language that lay people could understand, emphasizing the dramatic transformations he had witnessed, the violent patients who became calm, the anxious patients who found peace, the families reunited after years of separation. He downplayed the risks, the complications, the patients who showed no improvement or who emerged from surgery diminished in ways that were difficult to quantify but impossible to ignore. The media loved him. He was articulate, confident, willing to make bold claims at a time when most physicians were cautious and technical in their public statements. Newspapers ran headlines about miracle cures. Magazines published photo essays showing before and after pictures of lobotomy patients, their faces arranged to suggest the transformation from madness to sanity. The public, desperate for hope in the face of mental illness that touched nearly every family, embraced the narrative Freeman offered. This media promotion was controversial within the medical profession. Many physicians felt that Freeman was violating professional ethics by promoting an experimental procedure to the public rather than submitting it to proper scientific scrutiny. But it was also extraordinarily effective. Families began requesting lobotomies for their relatives. Hospital administrators, facing overcrowded wards and limited budgets, saw an intervention that promised to discharge patients and free up beds. The demand for the procedure grew rapidly, far faster than would have been possible through traditional medical channels. Still, the Freeman-Watts procedure required a hospital operating room, a trained neurosurgeon, general anesthesia, and several hours of surgical time. This limited how many lobotomies could be performed and where they could be done. Many state psychiatric hospitals lacked adequate surgical facilities. Many could not afford to hire neurosurgeons or could not convince neurosurgeons to work in what were often grim, underfunded institutions far from urban centers. Freeman chafed at these limitations. He envisioned lobotomy as a treatment that could be deployed on a massive scale, that could address the hundreds of thousands of patients languishing in institutions across America. But that would require a simpler procedure, something faster and less expensive, something that could be performed without elaborate surgical infrastructure. The answer came from an unexpected source. In 1937, an Italian psychiatrist named Amaro Fiamberti, medical director of a psychiatric hospital in Varese, developed an alternative approach to reaching the frontal lobes. Instead of drilling through the skull from above, Fiamberti accessed the brain through the eye sockets. The bone at the top of the eye socket is thin, easy to penetrate with a simple instrument. By inserting a needle or thin blade through this bone, a physician could reach the frontal lobes without elaborate surgery. Fiamberti used this transorbital approach to inject alcohol or formalin into the frontal lobes, similar to Moniz's original technique. He performed approximately 100 such procedures before World War II interrupted his work. His innovation was published in Italian medical journals, but received little international attention at the time. Freeman, however, learned of it and recognized its potential. For several years, Freeman continued performing standard lobotomies with Watts, but the idea of the transorbital approach remained in his mind, gestating, evolving. In 1945, he began experimenting in earnest. The story, which Freeman himself told many times, is that the inspiration came to him while making drinks in his home on Connecticut Avenue in Washington. He was cutting ice with an ice pick when he suddenly envisioned using a similar instrument to access the brain through the eye socket. Whether this moment of domestic inspiration actually occurred or was embellished in the retelling is unclear. What is certain is that Freeman began practicing on grapefruits and then on cadavers, developing a technique for transorbital lobotomy. He literally took an ice pick from his kitchen drawer and used it in his early experiments. The instrument was perfect for the purpose, thin enough to fit through the eye socket, strong enough to penetrate bone, long enough to reach the frontal lobes. The procedure Freeman developed was shockingly simple compared to traditional lobotomy. The patient would first be rendered unconscious using electroconvulsive shock. Freeman would use a portable ECT machine to induce several seizures, after which the patient would remain unconscious for several minutes. During this window, Freeman would lift the patient's eyelid, place the tip of his instrument against the thin bone at the top of the eye socket, and tap it through with a small hammer. Once the instrument had penetrated the skull, Freeman would manipulate it carefully, sweeping it from side to side to sever the white matter connections in the frontal lobe. He would repeat the process on the other side. The entire procedure could be completed in 10 minutes or less. There was no need for sterile surgical conditions, no need for general anesthesia beyond the electroshock, no need for a neurosurgeon. Freeman believed that any psychiatrist could learn to perform transorbital lobotomy with minimal training. On January 17, 1946, Freeman performed his first transorbital lobotomy on a live patient. Her name was Sally Ellen Ionesco, a 29-year-old housewife suffering from severe depression and violent outbursts. Freeman administered electroshock to render her unconscious, then performed the procedure in his office. When she regained consciousness, he sent her home in a taxicab. Within days, he reported, her depression had lifted. Her family was pleased. Freeman was elated. He immediately began performing more transorbital lobotomies. He did not tell Watts what he was planning, did not consult with his longtime partner about this radical modification of their procedure. When Watts discovered what Freeman was doing, he was appalled. This violated every principle of surgical practice. Brain operations performed in offices rather than operating rooms, without proper sterilization, without surgical backup in case of complications, without the careful protocols that made neurosurgery safe. Watts refused to participate. The disagreement between Freeman and Watts grew bitter. Watts argued that transorbital lobotomy was dangerous, reckless, and unethical. Freeman countered that it was practical, efficient, and necessary if lobotomy was to help the vast numbers of patients who needed it. The psychiatric hospitals, where most patients languished, could not support traditional neurosurgery, but they could certainly support a simple procedure performed by their own psychiatrists. In 1950, the partnership ended. Watts would continue performing traditional lobotomies for selected patients, always in proper surgical settings, always with appropriate precautions. Freeman would champion transorbital lobotomy, traveling across America to demonstrate the technique, to train other physicians, to promote what he increasingly saw as his mission to revolutionize psychiatric care. Freeman's vision was of assembly line psychiatry. He imagined a future where every psychiatric hospital had physicians trained in transorbital lobotomy, where the procedure could be performed rapidly and cheaply on thousands of patients, where the overcrowded back wards could be emptied, and patients returned to their communities. It was a vision born of genuine desire to help, combined with professional ambition and a troubling willingness to sacrifice caution for scale. He purchased a camper van and began traveling from hospital to hospital, particularly to state institutions in rural areas that had never had access to neurosurgical services. At each stop, he would demonstrate transorbital lobotomy, operating on patients while hospital staff watched and learned. He performed these demonstrations free of charge, seeing himself as an evangelist for a cause rather than a physician building a practice. The demonstrations were theatrical. Freeman had a showman's instinct for the dramatic gesture. He would sometimes perform lobotomies on both sides simultaneously, inserting instruments above both eyes at once and hammering them through in a coordinated motion. He called this his two-handed technique. Hospital staff who witnessed it were both impressed and disturbed by the casual confidence with which he worked, the speed of the procedure, the minimal equipment required. Freeman kept detailed records of every lobotomy he performed or supervised, photographs of patients before and after surgery, case notes documenting symptoms and outcomes, follow-up letters from families. He was building what he hoped would be an irrefutable body of evidence for lobotomy's effectiveness. But his record-keeping, while extensive, was also selective. He emphasized successes and downplayed failures. He maintained contact with patients who did well and lost track of those who did not. His published success rates would later be questioned by researchers who noted the absence of controlled comparisons and the subjectivity of his outcome measures. By the late 1940s, lobotomy had spread far beyond Freeman's direct influence. Physicians across America and around the world were performing the procedure. Some used the Freeman-Watts standard technique. Others adopted Freeman's transorbital approach. Still others developed their own variations. The number of lobotomies performed annually in the United States climbed rapidly. In 1945, approximately 150 lobotomies were performed. By 1949, the number had exceeded 5,000. By 1951, nearly 20,000 Americans had been lobotomized. The procedure had become mainstream psychiatry. Medical schools taught it. Psychiatric textbooks included chapters on psychosurgery. Professional organizations held conferences on surgical techniques and patient selection. What had been a radical experiment a decade earlier was now an accepted treatment performed in hospitals across the country, promoted by prominent physicians, and increasingly requested by families desperate for solutions. And in 1949, the medical establishment bestowed its highest honor on lobotomy's creator. António Egas Moniz was awarded the Nobel Prize in Physiology, or medicine, for his discovery of the therapeutic value of leucotomy in certain psychoses. He shared the prize with Swiss physiologist Walter Hess, whose work on the midbrain was unrelated to lobotomy. At 75 years old, Moniz finally received the recognition he had long sought. Walter Freeman, who had nominated Moniz for the prize, was jubilant. The Nobel Prize gave lobotomy a legitimacy that no amount of clinical reports could match. It silenced many critics, at least temporarily. It suggested that the international medical community had evaluated the evidence and concluded that lobotomy was a genuine breakthrough. Hospitals that had been hesitant to adopt the procedure now felt validated in doing so. The pace of lobotomies accelerated, but even as the prize was awarded, questions were accumulating. The patients who had been lobotomized in the late 1930s and early 1940s were now 5 or 10 years post-surgery. Long-term follow-up was revealing patterns that short-term assessments had missed. Many patients who had initially seemed improved were experiencing delayed complications, personality changes that became more apparent over time, cognitive deficits that subtly undermined their ability to function independently. And the indications for lobotomy were expanding in troubling ways. Originally promoted for severe, intractable psychosis, the procedure was now being performed for depression, for anxiety, for behavioral problems that would not traditionally have been considered psychiatric emergencies. Freeman himself was advocating lobotomy for an ever wider range of conditions. He suggested it for chronic pain patients, for those with severe obsessive-compulsive symptoms, even for children with behavioral difficulties. The threshold for what constituted a suitable candidate kept lowering. In the beginning, lobotomy had been reserved for patients who had spent years in institutions without improvement, for whom all other treatments had failed. Now it was being offered to people who had been ill for only months, who had not exhausted conventional therapies, who might have recovered with time and less invasive treatment. The transformation was complete. In 15 years, lobotomy had evolved from a desperate last resort to a routine intervention, from a procedure performed by a few pioneering physicians to one performed in hundreds of hospitals by thousands of practitioners, from an experimental operation to a Nobel Prize-winning breakthrough. The question was no longer whether lobotomy should be performed, but rather on whom, by what method, and how often. The answer to that question, it turned out, would have devastating consequences for tens of thousands of people, because what had been promoted as a miracle cure was revealing itself, slowly and undeniably, to be something far darker. The years between 1947 and 1954 represent lobotomy's peak, the period when the procedure was performed most frequently and with the least hesitation. These were years when state psychiatric hospitals, desperate for any solution to overcrowding, embraced psychosurgery as their best hope. When families, frightened by relatives whose behavior they could not control and could not understand, turned to lobotomy as a final answer. When the medical profession, still largely convinced of the procedure's value, performed operations with assembly line efficiency. The numbers tell a stark story. In 1949 alone, over 5,000 lobotomies were performed in the United States. To put this in perspective, this meant that on average, 14 Americans underwent brain surgery for psychiatric conditions every single day of that year. The cumulative total was climbing rapidly. By 1951, approximately 20,000 lobotomies had been performed across the country. Some estimates suggest the final number, by the time the procedure fell from favor in the late 1950s, reached 50,000 or more. Walter Freeman was at the center of this expansion. His transorbital technique had made lobotomy accessible to institutions that could never have supported traditional neurosurgery. Freeman traveled constantly, crisscrossing America in his personal vehicle, which critics would later derisively call the Lobotomobile, though Freeman himself never used that term. He preferred to think of himself as bringing enlightenment to the provinces, as a medical missionary carrying modern treatment to places that had been forgotten by academic medicine. His itinerary took him to state hospitals in West Virginia, Iowa, Nebraska, California, institutions that housed thousands of patients in conditions that had changed little since the 19th century. At each stop, Freeman would spend days or sometimes weeks demonstrating transorbital lobotomy to assembled staff, operating on patients the hospital had selected, training local psychiatrists in the technique. He performed these services without charge, accepting only his travel expenses, seeing himself as engaged in a humanitarian mission rather than a commercial enterprise. The scale of Freeman's work during these years is difficult to comprehend. In the summer of 1952, he traveled to West Virginia for what would become known as the West Virginia Lobotomy Project. Over a period of 12 days, he performed 228 transorbital lobotomies. On one particularly intense day, he lobotomized 25 women in succession. The procedures were performed in rapid sequence, one patient after another, with barely enough time between operations to clean instruments and prepare the next subject. The setting was clinical and efficient. Patients were lined up outside the procedure room, waiting their turn. Each would be brought in, strapped to a table, subjected to electroconvulsive shock until unconscious, then lobotomized. The ice pick would be inserted above each eye, tapped through the orbital bone, swept through the frontal lobe tissue, withdrawn. The patient would be moved to recovery, still unconscious from the electroshock, and the next patient would be brought in. Freeman worked with the focused intensity of a craftsman performing familiar work, each motion practiced and precise. Hospital administrators praised the efficiency. In less than 2 weeks, they had addressed 228 of their most difficult patients, individuals who required constant supervision, who were violent or self-destructive, or so deeply withdrawn that they required total care. The hope was that lobotomy would make these patients more manageable, would reduce the strain on staff, would perhaps allow some to be discharged. The reality would be more complicated. But in 1952, the complications were not yet fully apparent. What was visible was the immediate effect. Many lobotomized patients did become calmer, more docile, easier to manage. The violent outbursts that had required multiple attendants to control would cease. The agitation that had kept patients pacing wards for hours would diminish. From an administrative perspective, from the standpoint of institutions trying to maintain order with inadequate staff, these changes looked like success. The patients who underwent lobotomy during these peak years came from all segments of society, but certain patterns emerged from the records. Women were disproportionately represented. Studies from the period show that nearly 60% of American lobotomy patients were female. In some regions, the ECHO disparity was even greater. In Ontario, Canada, 74% of lobotomies performed between 1948 and 1952 were on women. The reasons for this gender imbalance are complex and disturbing. Some of it reflected genuine differences in diagnosis rates, as women were more likely to be diagnosed with depression and anxiety disorders, for which lobotomy was increasingly recommended. But much of it reflected social attitudes about acceptable female behavior. Women who were too emotional, too difficult, too unwilling to conform to traditional roles were seen as suitable candidates for an operation that promised to make them more compliant, more manageable, more tractable. The case of Rosemary Kennedy illustrates this dynamic with particular clarity. Rosemary was born in 1918, the third child of Joseph and Rose Kennedy. From early childhood, it was clear that she developed more slowly than her siblings. She struggled in school, had difficulty with tasks that came easily to her brothers, and sisters required additional help and supervision. The exact nature of her condition was never definitively established. Modern analysis suggests she may have experienced oxygen deprivation during birth, possibly resulting in what we would now recognize as an intellectual disability. Her family kept her at home through her childhood and adolescence, which was unusual for the time. Most families with intellectually disabled children, particularly wealthy families, would have institutionalized them. The Kennedys instead included Rosemary in family life, provided her with special tutors, brought her along on family trips, including the years they spent in England when Joseph Kennedy served as ambassador. But as Rosemary entered her 20s, her behavior became more difficult for the family to manage. She had violent mood swings, would become angry and aggressive, particularly toward her mother. She was increasingly resistant to the constraints placed on her life. When sent to a convent, she began sneaking out at night, going to bars, meeting men. For Joseph Kennedy, who was obsessively concerned with his family's reputation and who had political ambitions for his sons, this behavior was intolerable. In 1941, Kennedy began investigating lobotomy. He consulted with Walter Freeman and James Watts, who were by then the leading practitioners in America. They assured him that the procedure could help calm Rosemary's mood swings, could make her more controllable, more content with her limited life. Kennedy made the decision to proceed without consulting his wife or other children. He told Rose only after the operation had been scheduled. In November 1941, 23-year-old Rosemary Kennedy was brought to George Washington University Hospital. The operation was performed by Freeman and Watts using their standard prefrontal technique. Years later, Watts would describe the procedure in an interview. They went through the top of the head, he recalled. Rosemary was awake, given only a mild tranquilizer. They made small incisions on both sides of her brain, no more than an inch each. The instrument they used was described as resembling a butter knife. As they cut into the brain tissue, they had Rosemary talk to them. They asked her to recite the Lord's Prayer, then to sing God Bless America, then to count backward. They were listening for the point at which her responses became incoherent, when her words slurred and lost meaning. That was how they knew they had cut enough of the brain tissue. When Rosemary could no longer speak clearly, they stopped. The operation was a catastrophe. Rosemary left the hospital unable to walk without assistance, unable to speak more than a few words, unable to care for herself in any way. Her mental capacity had regressed to that of a small child. She was incontinent. Her arm was partially paralyzed. The vibrant young woman who had attended society events and traveled with her family was gone, replaced by someone who would require total care for the rest of her life. Joseph Kennedy had Rosemary moved to Craig House, a private psychiatric hospital in New York, where she spent months in physical therapy. She regained some mobility, learned to walk again, though with a pronounced limp. But she never regained the ability to speak coherently or to function independently. In 1949, she was transferred to St. Coletta School for Exceptional Children in Jefferson, Wisconsin, a Catholic institution for people with developmental disabilities. She would remain there for the next 56 years. The family did not visit. Joseph Kennedy never saw his daughter again after authorizing her lobotomy. Rose Kennedy, who had not been told about the operation until after it was performed, stayed away for 20 years. The younger Kennedy children were told that Rosemary was in an institution, but the truth of what had been done to her was kept hidden. When John Kennedy ran for political office, the family explained Rosemary's absence by saying she was reclusive, later that she was mentally retarded from birth. The lobotomy was not mentioned. The truth began to emerge only decades later. In 1962, Eunice Kennedy Shriver wrote an article for the Saturday Evening Post discussing her sister and the family's commitment to helping people with intellectual disabilities. But even this article did not mention the lobotomy. That fact was first revealed publicly in 1987, when historian Doris Kearns Goodwin published The Fitzgeralds and the Kennedys, and included the story of Rosemary's operation. Rosemary Kennedy's case is exceptional only in its prominence. The basic pattern, a family unable to cope with a difficult relative, doctors promising a surgical solution, an operation that left the patient permanently diminished, was repeated thousands of times during lobotomy's peak years. The vast majority of these cases left no historical record beyond brief entries in hospital logs. The patients once lobotomized often disappeared into institutions or into family care, their diminished lives unchronicled and unmourned. Children were particularly vulnerable. Freeman himself performed lobotomies on 19 children, the youngest only 4 years old. Other physicians lobotomized children as well, though the total number is difficult to establish with certainty. The case of Howard Dully represents one of the few where the patient later recovered sufficiently to tell his own story. In 1960, Howard Dully was 12 years old, living with his father and stepmother in California. He was not mentally ill in any clinical sense. He was a normal boy, perhaps somewhat difficult, resistant to his stepmother's authority, prone to daydreaming and minor misbehavior. His stepmother found him impossible to control and sought help. She brought him to Walter Freeman, who by then had been performing lobotomies for over 20 years. Freeman's case notes on Howard Dully reveal the thinking behind this operation. The boy was unapproachable by psychotherapy, Freeman wrote. He turned lights on during the day. He hated to wash. He wore sweaters on hot days. He was, in Freeman's assessment, a suitable candidate for lobotomy, a procedure that might change his personality and make him more manageable. Howard's father was reluctant, but eventually agreed. On December 16, 1960, Freeman performed a transorbital lobotomy on the 12-year-old boy in his office. Howard remembers being taken there, remembers the electroshock that rendered him unconscious, remembers nothing of the procedure itself. When he woke, he was sent home. The operation had cost his parents less than $200. The immediate effects were subtle. Howard did not become a vegetable, did not lose the ability to speak or walk. But something had changed. He felt different, felt a flatness to his emotions, a distance between himself and the world. As he grew into adolescence and adulthood, he struggled with relationships, with addiction, with a sense that something fundamental had been taken from him. It would be decades before he obtained his medical records and learned exactly what had been done to him, before he began the long process of trying to understand and come to terms with his lobotomy. The demographics of lobotomy patients during the peak years reveal other troubling patterns beyond gender and age. Poor patients were disproportionately represented, particularly in state hospitals where most operations were performed. Wealthy families had access to private psychiatric care, to extended psychotherapy, to comfortable sanitariums where relatives could be cared for indefinitely. Poor families had only state hospitals, and state hospitals had only custody and increasingly lobotomy. Immigrant populations were also overrepresented. Language barriers and cultural differences could make patients seem more disturbed than they were. A person who could not communicate effectively in English, who behaved according to cultural norms that differed from mainstream American expectations, might be labeled as psychotic and recommended for surgery. The racial demographics of lobotomy are harder to establish with certainty, as many hospital records from this period did not systematically document race. But the available evidence suggests that people of color, when institutionalized, were also subjected to lobotomy at significant rates. The expansion of lobotomy's indications during the peak years meant that the procedure was performed for increasingly minor conditions. What had begun as a last resort for severe, chronic psychosis was now being offered for depression that had lasted only months, for anxiety that might have responded to less invasive treatment, for behavioral difficulties that were more social than medical. Freeman advocated lobotomy for chronic pain patients, arguing that the procedure could sever the emotional component of pain even if it could not eliminate the physical sensation. He performed lobotomies on patients with severe headaches, with back pain, with conditions that had no psychiatric component, but that caused sufficient distress to seem like reasonable targets for intervention. The consent process, when there was one, was minimal by modern standards. Patients in state hospitals often had no voice in the decision. Institutional psychiatrists would recommend lobotomy, administrators would approve it, and the operation would be performed whether or not the patient agreed. For patients who were legally competent, consent might be obtained, but it was rarely informed in any meaningful sense. Families were told that lobotomy could help, that it was a recognized treatment, that many patients improved. They were less often told about the risks, the permanent nature of brain damage, the possibility that their relative might emerge from surgery fundamentally changed in ways that were impossible to predict. Some patients sought lobotomy themselves, desperate enough to try anything that promised relief. But most did not choose it voluntarily. Most were subjected to it by others who believed they knew what was best, who prioritized social order over individual autonomy, who saw the procedure as a solution to problems that were as much about institutional management as about individual suffering. By 1954, the peak had passed. The number of lobotomies being performed annually was beginning to decline. But that decline was gradual, and thousands more operations would be performed before the procedure was finally abandoned. The damage had been done. tens of thousands of people had been lobotomized, their brains irreversibly altered, their futures fundamentally changed by operations that promised cure but delivered something far more ambiguous and often far more tragic. The promises made about lobotomy were straightforward and appealing. The procedure would calm agitated patients, would lift depression, would free people from obsessive thoughts and crippling anxiety. Patients would return to their families, resume productive lives, be cured of conditions that had seemed incurable. Walter Freeman spoke of liberating people from mental prisons, of giving them back their futures. The reality, as it emerged through years of follow-up studies and countless individual stories, was far more complicated and often devastating. What lobotomy actually did to the human brain was poorly understood even by the physicians performing it. The frontal lobes, the target of the operation, are involved in complex executive functions including planning, decision-making, emotional regulation, impulse control, and personality expression. These are the capacities that make us distinctly human, that allow us to imagine futures and work toward them, to moderate our immediate reactions in service of long-term goals, to experience the full range of human emotion with appropriate depth and nuance, severing connections within the frontal lobes or between the frontal lobes and other brain regions did not simply eliminate pathological symptoms. It could not surgically extract depression while leaving joy intact, could not remove anxiety while preserving appropriate caution. Instead, it damaged the entire system of emotional and cognitive regulation, creating changes that were sometimes subtle and sometimes catastrophic, but always permanent. Freeman himself coined a phrase for the common outcome of lobotomy. He called it surgically induced childhood. He argued that this was a necessary stage in the patient's recovery, a kind of reset that would allow them to rebuild healthier patterns of thought and emotion. But this was rationalization masquerading as theory. What Freeman was describing and attempting to justify was the reduction of adult human beings to a childlike state of dependency and diminished capacity. The most commonly reported effects of lobotomy included profound apathy. Patients who had been agitated became calm, but the calm was not peace. It was flatness, an absence of motivation and drive. They would sit for hours without moving, without speaking, without showing interest in anything around them. When asked questions, they might answer, but their responses were brief and showed little engagement. They did not initiate conversation, did not seek out activities, did not express desires or preferences. Along with apathy came passivity. Lobotomized patients would comply with instructions, but rarely took independent action. If told to eat, they would eat. If told to go to bed, they would go. But left to themselves, they might sit motionless, waiting for external direction. This passivity made them easier to manage in institutional settings, which was precisely what many hospital administrators valued. But it also meant they had lost something essential to autonomous human existence. Cognitive functions were affected in ways that were sometimes difficult to measure, but clearly present. Patients showed poor ability to concentrate, struggled with complex tasks that required sustained attention, had difficulty learning new information. Their intellectual capacity seemed diminished, though standardized testing often showed less dramatic changes than were apparent in daily function. The problem was not simply that they had lost IQ points. It was that they had lost the ability to deploy whatever intelligence they retained in purposeful ways. The emotional changes were perhaps the most disturbing. Lobotomized patients experienced what physicians described as a decreased depth and intensity of emotional response to life. They might smile when something pleasant occurred, might frown when uncomfortable. But these reactions seemed automatic, lacking the richness and complexity of normal human emotion. They did not laugh deeply, did not cry except in rare circumstances, did not show anger or fear except in muted forms. The full spectrum of human feeling had been compressed into a narrow band of shallow affect. Freeman kept detailed notes on his patients, and some of these case descriptions reveal the reality behind his claims of success. He wrote of one 29-year-old woman who, following lobotomy, became what he called a smiling, lazy, and satisfactory patient with the personality of an oyster. She could not remember Freeman's name despite seeing him repeatedly. She would endlessly pour coffee from an empty pot, repeating the action mechanically without recognizing its futility. When her parents struggled to manage her behavior at home, Freeman advised them to use a system of rewards and punishments, giving her ice cream when she complied with instructions and smacking her when she did not, as one might train a dog. This was a patient Freeman considered a success. She was no longer agitated or depressed. She did not cause problems for her family or require institutional care. By the crude metrics Freeman used to evaluate outcomes, she had improved. But the woman who emerged from surgery bore little resemblance to the person who had entered the operating room. Her personality had not been adjusted. It had been erased. Many patients showed worse outcomes. Some became completely incapacitated, unable to walk or speak coherently, requiring total care for the rest of their lives. Rosemary Kennedy represented this category, though her prominence was unusual. Most patients who suffered such catastrophic results disappeared into institutions or into family care, their existence maintained, but their lives essentially over. Physical complications were also common, though Freeman and other lobotomy advocates downplayed them in their published reports. Brain hemorrhage could occur during or immediately after surgery, sometimes proving fatal. Approximately 15% of Freeman's own patients died as a direct result of the procedure, though he rarely emphasized this statistic when promoting lobotomy. Infection was another risk, particularly with transorbital procedures performed outside sterile operating rooms. Seizures developed in some patients, sometimes immediately, sometimes years after surgery. Persistent headaches plagued others. The mortality rate varied depending on the technique used and the skill of the operator. But even conservative estimates suggest that hundreds of Americans died from lobotomy itself, not from the conditions it was meant to treat. These deaths were often attributed to other causes in official records, making the true toll difficult to establish. A patient who developed a brain hemorrhage during surgery might be listed as dying from natural causes. One who succumbed to infection weeks later might not have the lobotomy mentioned on the death certificate at all. For patients who survived the operation and avoided the most catastrophic outcomes, the long-term trajectory was often one of gradual decline. Initial improvements in agitation or anxiety might fade over months or years, leaving the patient with the same psychiatric symptoms they had started with, but now compounded by the cognitive and emotional deficits created by surgery. They were worse off than before, not better, but the damage could not be undone. The economic incentives that drove lobotomy's widespread adoption are uncomfortable to examine, but essential to understanding how the procedure spread so rapidly despite its poor outcomes. State psychiatric hospitals in the 1940s and early 1950s were desperately overcrowded and chronically underfunded. Each patient represented a financial burden that stretched year after year, sometimes for decades. The cost of housing, feeding, supervising, and providing minimal care for someone institutionalized for 20 or 30 years was substantial. Lobotomy offered a way to reduce these costs. The procedure itself was inexpensive, particularly in its transorbital form. $200 or less per patient, a trivial expense compared to years of institutional care. And if the operation made patients more manageable, reduced their need for constant supervision, perhaps even allowed them to be discharged, the savings multiplied. Hospital administrators who approved large numbers of lobotomies were not necessarily callous or cruel. They were dealing with impossible situations, trying to provide some level of care to far more patients than their institutions could adequately serve, with budgets that never matched the need. But this economic logic led to decisions that prioritized institutional convenience over patient welfare. The question was not always whether lobotomy would genuinely help a patient recover and return to a fulfilling life. Often the question was whether it would make the patient easier to care for, less disruptive, less demanding of staff time and resources. A lobotomized patient who sat quietly in a ward, who complied with instructions without resistance, who required less supervision even if they required continued institutional care, was considered an improvement from an administrative perspective. This calculus was particularly stark in state hospitals, which served primarily poor patients who had no families willing or able to care for them. These were the most vulnerable people in American society, individuals who had essentially no rights, no advocates, no voice in decisions about their own treatment. If institutional psychiatrists recommended lobotomy, there was rarely anyone to question the decision or to insist on alternatives. The consent process, when it existed at all, was profoundly inadequate. For patients who were legally competent, families might be asked to sign consent forms, but the information provided was selective and often misleading. Families were told that lobotomy was a recognized treatment, that many patients improved, that it offered hope where other treatments had failed. They were shown Freeman's carefully curated collection of before and after photographs, images chosen to suggest dramatic positive transformation. What families were not told, or were told only minimally, was that the operation permanently destroyed brain tissue, that many patients showed no improvement or deteriorated after surgery, that the death rate was significant, that the changes in personality could be profound and irreversible. They were not presented with long-term outcome data because such data barely existed. Most follow-up studies were brief, covering weeks or months rather than years, and were conducted by physicians who had a professional and personal investment in demonstrating lobotomy's success. For institutionalized patients, consent was often not sought at all. These were people who had been committed to state hospitals, sometimes involuntarily, sometimes so long ago that their legal status was ambiguous. Institutional psychiatrists had broad authority to make treatment decisions. If they believed lobotomy was indicated, they could order it performed. The patient's own wishes, assuming they were capable of expressing them, were considered secondary to professional medical judgment. This medical paternalism was not unique to lobotomy. It characterized much of medicine in the era before patients' rights movements and informed consent requirements transformed the doctor-patient relationship. Physicians were trained to see themselves as benevolent authorities who knew what was best for their patients and had both the right and the duty to make decisions on their behalf. Patients, particularly psychiatric patients, were viewed as too ill, too confused, too compromised to participate meaningfully in decisions about their own care. But the consequences of this paternalism were particularly severe when the treatment in question permanently altered the brain. A patient subjected to insulin shock therapy or electroconvulsive treatment might suffer harm, but those treatments were not irreversible. A patient given sedatives could eventually be taken off them. A patient confined to an institution might someday be released. But a patient who underwent lobotomy was permanently changed. The decision made by doctors and family members on their behalf could not be unmade. Children lobotomized during this period had no voice at all in the process. They were subjected to operations they could not understand for reasons they could not grasp, with consequences that would shape the rest of their lives. Howard Daly was 12 when Freeman lobotomized him for being a difficult child. He spent decades struggling with the aftermath, trying to understand what had been done to him and why. His was not an isolated case, but rather one of the few that eventually became public. The 19 children Freeman lobotomized included a 4-year-old, an age at which normal childhood behavior includes tantrums, defiance, emotional volatility, all the things that might be misinterpreted as psychiatric symptoms by adults determined to see pathology. What must it be like to reach adulthood and learn that at age 4, someone decided to destroy part of your brain because you were too difficult to manage? The question haunts anyone who examines this history carefully. By the mid-1950s, evidence of lobotomy's failures was accumulating to the point where it could no longer be ignored or explained away. Long-term follow-up studies were revealing that initial improvements often did not last, that side effects were more common and more severe than had been reported, that many patients were worse off years after surgery than they had been before. The gap between Freeman's optimistic claims and the lived reality of lobotomized patients was becoming too wide to bridge. But the procedure had been performed on tens or thousands of people by this point. The damage was done, and for the medical profession, acknowledging the full extent of that damage would require confronting uncomfortable truths about how such a destructive treatment had been embraced so enthusiastically, promoted so aggressively, and performed so widely with so little evidence of genuine benefit. The decline of lobotomy did not happen suddenly. There was no single moment when the medical community collectively recognized its error and abandoned the procedure. Instead, the fall was gradual, uneven, characterized by mounting criticism, defensive responses from advocates, and the slow accumulation of evidence that could no longer be dismissed or explained away. The transformation from accepted treatment to discredited practice took nearly a decade, and even then, lobotomies continued to be performed in some places well into the 1970s, long after the procedure had been rejected by mainstream psychiatry. The first significant opposition came from within the neurosurgical community. Neurosurgeons had been skeptical of lobotomy from the beginning, viewing it as a violation of fundamental surgical principles. Brain surgery was a delicate specialty that required years of training, meticulous technique, and respect for the complexity of the organ being operated upon. The idea of deliberately destroying healthy brain tissue to treat psychological symptoms struck many neurosurgeons as barbaric, a return to a more primitive era of medicine. These concerns intensified as Freeman's transorbital technique spread. Neurosurgeons watched with growing alarm as psychiatrists with minimal surgical training began performing brain operations in office settings without proper sterilization, without backup systems in case of complications, without the careful protocols that made neurosurgery as safe as possible. This was not merely a theoretical concern. Reports of deaths and severe complications from transorbital lobotomies were circulating within the medical community, though they were rarely published in journals or acknowledged publicly. The Soviet Union became the first country to officially ban lobotomy, prohibiting the procedure in December 1950. The decision was partly political, reflecting Soviet criticism of Western medicine and psychiatry, but it also drew on legitimate medical concerns about the operation's efficacy and safety. Other European countries began restricting lobotomy as well, though few implemented outright bans. Instead, they imposed stricter requirements for patient selection, demanded more rigorous consent procedures, limited who could perform the operation and under what circumstances. In the United States, criticism grew more pointed throughout the early 1950s. Medical journals published articles questioning Freeman's published success rates, noting the absence of controlled studies, pointing out the subjective nature of outcome assessments. Some physicians who had initially embraced lobotomy began publishing their own follow-up studies, and these painted a less optimistic picture than Freeman's reports. They documented high rates of personality change, cognitive impairment, and cases where initial improvement had given way to long-term deterioration. The medical establishment's response to these criticisms was complicated by the 1949 Nobel Prize. How could the profession acknowledge that lobotomy was fundamentally flawed when the procedure's inventor had been awarded medicine's highest honor just a few years earlier? The Nobel Prize lent lobotomy a legitimacy that made it harder to challenge, created institutional momentum that carried the procedure forward even as evidence mounted against it. But the most powerful force driving lobotomy's decline was not medical criticism or institutional caution. It was the arrival of a genuine alternative, a treatment that could accomplish what lobotomy had promised to do, calming agitated patients and reducing psychotic symptoms, but without destroying their brains. The story begins in France in the early 1950s with a military surgeon named Henri Laborie. Laborie was experimenting with various drugs in an attempt to develop better anesthetics for surgical patients. He was particularly interested in compounds that might reduce the shock and trauma associated with major operations. One of the drugs he tested was chlorpromazine, a synthetic chemical that had been developed by the pharmaceutical company Rhône-Poulenc as an antihistamine. Laborie noticed something unexpected. Chlorpromazine did not function well as an anesthetic in the traditional sense. Patients who received it did not lose consciousness, but they did become remarkably calm, emotionally detached from their surroundings, indifferent to things that would normally cause anxiety or distress. Laborie recognized that this property might be valuable in psychiatry and shared his observations with psychiatric colleagues, French psychiatrists Jean Delay and Pierre Deniquet conducted the first systematic trials of chlorpromazine in psychiatric patients at Sainte-Anne Hospital in Paris. They administered the drug to patients with various forms of psychosis, particularly schizophrenia, and documented the results carefully. what they observed was striking. Patients who had been agitated, delusional, hallucinatory, unreachable through conventional therapeutic approaches began to show improvement. The hallucinations did not disappear entirely, but they became less vivid, less compelling. The delusions remained, but seemed to matter less to the patients. The agitation diminished. DeLay and Denneker published their findings in 1952, describing chlorpromazine's effects as inducing a state of emotional detachment and reduced reactivity that they termed neuroleptic syndrome. The word neuroleptic, suggested by DeLay, meant roughly that which takes the nerve, or that which seizes the nervous system. It was an apt description of the drug's action, though the term would later fall somewhat out of favor as newer medications were developed. The pharmaceutical industry recognized chlorpromazine's potential immediately. Ron Poulenc introduced it to the French medical market in late 1952 under the trade name Largactil, meaning large activity, marketing it for various uses, including surgery, psychiatry, and treatment of nausea. The American pharmaceutical company Smith, Kline and French acquired the rights to market chlorpromazine in the United States and submitted it to the Food and Drug Administration for approval. In 1954, the FDA approved chlorpromazine for psychiatric use in America under the trade name Thorazine. The marketing was brilliant and somewhat provocative. Smith, Kline and French promoted Thorazine as a chemical lobotomy, explicitly positioning it as an alternative to surgical intervention. The message was clear. You could achieve similar behavioral effects to lobotomy, the calming of agitated patients, the reduction of psychotic symptoms, but without drilling through skulls or destroying brain tissue. The uptake was extraordinarily rapid. Within 8 months of Thorazine's introduction to the American market, it had been administered to over 2 million patients. Psychiatric hospitals embraced it eagerly. Here, finally, was a tool that could help manage the massive overcrowded wards without resorting to physical restraints or surgical intervention. Patients who might previously have been candidates for lobotomy could instead be given Thorazine. Those who had already been lobotomized could be given the drug as well, potentially managing whatever psychiatric symptoms remained. The effects were dramatic at an institutional level. State psychiatric hospital populations, which had peaked at around 560,000 patients in 1955, began to decline. By 1965, just a decade later, the number had dropped to approximately 450,000. This reduction was not primarily because patients were being cured and discharged, though some were able to leave hospitals with the help of antipsychotic medication. Rather, it reflected a shift in how psychiatric care was being conceptualized and delivered. Thorazine and the other antipsychotic medications that quickly followed, drugs like Haldol and Stelazine, made it possible to manage psychotic patients outside institutional settings. Patients who would previously have required the constant supervision available only in hospitals could now be maintained in the community with medication and outpatient care. This aligned with broader social movements toward deinstitutionalization, toward closing the massive state hospitals and developing community-based mental health services. The introduction of effective antipsychotic medication did not mean psychiatric treatment had suddenly become perfect or even particularly good. Thorazine and similar drugs had significant side effects. Patients developed movement disorders, particularly tardive dyskinesia, a condition involving involuntary repetitive movements that could become permanent even after the medication was stopped. They experienced sedation, weight gain, metabolic changes. The drugs were not cures, did not address the underlying causes of psychosis, and were sometimes used coercively in ways that raised their own ethical concerns. But compared to lobotomy, antipsychotic medication offered crucial advantages. The effects were reversible. If a medication caused intolerable side effects or proved ineffective, it could be stopped, and the patient's brain would not be permanently damaged. Different medications could be tried. Dosages could be adjusted. There was flexibility and the possibility of refinement in ways that surgery could never offer. The availability of antipsychotic medication fundamentally undermined the justification for lobotomy. Freeman and other lobotomy advocates had always argued that the procedure was justified by the absence of alternatives, that desperate situations required desperate measures, that permanent brain damage was acceptable because there was no other way to help severely ill patients. But now, there was another way. The desperation argument collapsed. Freeman recognized the threat that Thorazine posed to his life's work. He argued that medication and surgery addressed different aspects of mental illness, that lobotomy was still necessary for patients who did not respond to drugs, that the two treatments were complementary rather than competing. He continued performing transorbital lobotomies throughout the 1950s and into the 1960s, traveling to state hospitals, demonstrating his technique, insisting that psychosurgery remained valuable. But the number of lobotomies being performed annually dropped sharply. From over 5,000 in 1949, the numbers fell to perhaps a few hundred by the late 1950s. Some hospitals stopped performing the procedure entirely. Others restricted it to very limited circumstances, requiring extensive evaluation and approval processes before surgery could be performed. The easy access to lobotomy that had characterized the peak years was gone. Cultural attitudes were shifting as well. The 1960s brought increasing skepticism toward institutional authority and traditional hierarchies. The civil rights movement's emphasis on individual autonomy and resistance to oppressive systems extended to patients' rights. Activists began challenging the power that doctors and hospitals had over institutionalized individuals, demanding that patients have more say in their own treatment, that commitment and treatment decisions be subject to legal oversight. Exposés of conditions in state psychiatric hospitals, many written by conscientious objectors who had worked in these institutions during World War II in lieu of combat service, shocked the American public. Life magazine published a photo essay titled Bedlam 1946 that showed the horrific conditions in several state hospitals. Images of naked patients crowded into barren wards, of people restrained and isolated, of facilities that looked more like prisons than hospitals, generated outrage and calls for reform. In this changing climate, lobotomy came to symbolize everything that was wrong with institutional psychiatry. It represented medical paternalism, the arrogant assumption that doctors knew best and patients had no right to refuse treatment. It represented the prioritization of institutional convenience over individual well-being. It represented the willingness to damage people permanently in the name of social control disguised as therapy. Popular culture reflected and reinforced this changing perception. Novels like Ken Kesey's One Flew Over the Cuckoo's Nest, published in 1962, depicted lobotomy as a tool of oppression, a way to silence and control people who challenged authority. The book's climax involves the protagonist being lobotomized as punishment for his rebellious behavior. When the novel was adapted into a film in 1975, it brought these themes to an even wider audience, cementing lobotomy's place in the public imagination as a symbol of psychiatric abuse. Freeman's reputation crumbled in parallel with the procedure's decline. The medical establishment that had once celebrated him as an innovator began to view him as an embarrassment, a relic of a more barbaric era. His lobbying for continued use of lobotomy made him seem increasingly out of touch. Younger psychiatrists trained in the era of psychopharmacology and influenced by the patients' rights movement looked at his work with horror rather than admiration. The final blow to Freeman's career came in 1967. He performed a transorbital lobotomy on a patient who had already undergone 2 previous lobotomies at his hands. The patient died from a brain hemorrhage during the procedure. The hospital where Freeman had been operating revoked his surgical privileges. He was banned from performing any further operations. For a man who had performed or supervised over 3,500 lobotomies during his career, who had built his entire professional identity around psychosurgery, this was a devastating end. Freeman spent his remaining years traveling in his camper van, visiting former patients, trying desperately to document that his work had been worthwhile, that the people he had operated on had lived better lives because of what he had done to them. He died in 1972, largely discredited within his profession, remembered more for the damage he had caused than for the help he had intended. By the mid-1970s, lobotomy had effectively disappeared from mainstream American psychiatric practice. A few modified psychosurgical procedures continued to be performed in specialized centers for very limited indications like severe treatment-resistant obsessive-compulsive disorder. But these were rare and bore little resemblance to the mass lobotomies of the 1940s and 1950s. The era of widespread psychosurgery was over, ended by a combination of medical evidence, pharmaceutical innovation, cultural change, and growing recognition of the profound ethical violations the procedure represented. The question of what remains from the lobotomy era is both simple and complex. The simple answer is that lobotomy itself, in the form practiced by Freeman and thousands of other physicians during the 1940s and 1950s, no longer exists in mainstream medicine. It has been abandoned, discredited, relegated to the category of historical medical errors, alongside bloodletting and trepanation. No major hospital in America performs prefrontal lobotomies today. The procedure is banned outright in several countries. Where it is not explicitly illegal, it is so thoroughly rejected by medical consensus that the distinction hardly matters. But the complete answer requires acknowledging that psychosurgery, the broader category of brain operations intended to treat psychiatric conditions, has not entirely disappeared. Modified forms continue to exist at the margins of psychiatric practice, performed in a handful of specialized centers, under strict oversight, and only for the most severe, treatment-resistant cases. These modern procedures bear little resemblance to the lobotomies of the past. They use stereotactic techniques that allow for millimeter-precise targeting of specific brain regions, destroying tiny amounts of tissue rather than sweeping broadly through the frontal lobes. Procedures like bilateral cingulotomy, which targets a small part of the brain involved in emotional processing, or capsulotomy, which affects circuits related to obsessive-compulsive symptoms, are performed perhaps a few dozen times per year across the entire country. The patients who undergo these operations today are people for whom everything else has failed. They have tried multiple medications, various forms of psychotherapy, electroconvulsive treatment, experimental protocols. They are so disabled by their symptoms that they cannot work, cannot maintain relationships, sometimes cannot leave their homes. For these rare individuals, modern psychosurgery is offered as a last resort, and only after extensive evaluation by multiple specialists, detailed informed consent processes, and ethics committee review. The outcomes of these modern procedures are mixed. Some patients experience significant improvement in their symptoms. Others show minimal change. The side effects tend to be less severe than those associated with lobotomy, partly because far less brain tissue is destroyed. But personality changes and cognitive effects can still occur. The procedures remain controversial within psychiatry, with some practitioners arguing they should never be performed and others defending them as appropriate options for carefully selected patients when nothing else has helped. This persistence of psychosurgery in modified form raises uncomfortable questions. If lobotomy was such a clear error, such an obvious violation of medical ethics, why does any form of psychiatric brain surgery continue? The answer reflects the complexity of medical decision-making in desperate situations, the balance between doing harm and allowing suffering to continue untreated, the reality that some psychiatric conditions remain extraordinarily difficult to help even with modern tools. But the lessons learned from lobotomy's history are supposed to prevent the errors of the past from being repeated. Modern psychosurgery operates under constraints that did not exist in Freeman's era. Informed consent is required, meaning patients must understand what will be done to them, what the risks are, what alternatives exist. They must be capable of making such decisions, and their consent must be voluntary, not coerced by family members or institutional authorities. Independent review by ethics committees is mandatory. Long-term follow-up is standard. The transparency and oversight that were absent during lobotomy's peak years are now required. The broader legacy of lobotomy extends beyond the specific question of psychosurgery. The procedure's history has become a touchstone in medical ethics. A cautionary tale invoked whenever new interventions are proposed, whenever the medical profession seems to be embracing something with insufficient evidence, whenever enthusiasm threatens to outpace careful evaluation. Medical students learn about lobotomy as an example of how badly things can go wrong when economic incentives, professional ambition, and societal pressures combine to override scientific rigor and patient welfare. The story illustrates the dangers of medical paternalism, the importance of informed consent, the need for controlled studies before declaring treatments effective, the requirement for long-term follow-up to understand the full consequences of interventions. Lobotomy also features prominently in discussions of patients' rights and disability rights. The procedure was performed disproportionately on vulnerable populations: women, children, the poor, the institutionalized, people who had little power to resist even when they understood what was being proposed. The violation of their autonomy, the permanent damage done to them by others who claimed to be acting in their best interests, underscores why patients must have the right to refuse treatment, why substitute decision-makers must be held to high standards of accountability, why society must protect those who cannot protect themselves. The scientific legacy is more ambiguous. Lobotomy did not advance understanding of the brain or mental illness in any meaningful way. It was based on theories that proved to be wrong, performed without the kind of careful observation and documentation that might have generated useful knowledge. The thousands of lobotomies performed represent From a scientific perspective, a massive lost opportunity. If even a fraction of the effort devoted to promoting and performing the procedure had instead been invested in rigorous research, in controlled studies, in careful long-term follow-up, something of value might have emerged from the tragedy. But perhaps the most important legacy is the one carried by the people who were lobotomized and by their families. Tens of thousands of Americans underwent this operation. Many are dead now, their lives ended decades ago. But some survived into old age, lived long enough to see lobotomy repudiated, long enough to understand that what had been done to them was now considered a mistake. Rosemary Kennedy died in 2005 at the age of 86. She spent the last 64 years of her life at St. Coletta School in Wisconsin, cared for by nuns, visited occasionally by family members. Once her father's death in 1969 made such visits permissible. She never recovered the abilities taken from her in November 1941. She learned to walk again, though with difficulty. She could speak a few words and phrases, though never coherently. She required total care until the day she died. Her story, once it became public, helped inspire movements for disability rights and for better treatment of people with intellectual disabilities. Her sister Eunice Kennedy Shriver founded the Special Olympics in 1968, driven at least in part by what had happened to Rosemary. The Kennedy family, perhaps seeking to atone for Joseph Kennedy's decision to lobotomize his daughter, became major supporters of research into intellectual disabilities and advocates for policies supporting people with special needs. But no amount of advocacy or charitable work could undo what was done to Rosemary herself. She remained disabled, diminished, her potential destroyed by an operation performed without her knowledge or consent, justified by concerns about family reputation and control. Her story stands as a reminder that even wealthy, prominent families with access to the best medical care could make catastrophic decisions, could allow their daughters to be permanently damaged in the name of managing difficult behavior. Howard Dully, lobotomized at age 12, survived to tell his own story. In 2005, he published a memoir titled My Lobotomy, describing what it was like to grow up, knowing something had been done to his brain, but not understanding exactly what, to struggle with relationships and addiction and a pervasive sense of disconnection, to finally obtain his medical records and confront the reality of what Freeman had done to him. Dully's book is remarkable for its relative lack of bitterness. He describes Freeman as misguided rather than evil, acknowledges that his stepmother, who pushed for the operation, was probably struggling with her own issues, recognizes that his father faced an impossible situation. But he also makes clear the cost he paid, the decades of difficulty that might have been avoided if he had been allowed to grow up with his brain intact. His story, like Rosemary Kennedy's, illustrates the human reality behind the statistics. The individual lives altered by decisions made in pursuit of social control, disguised as medical treatment. Most lobotomy patients never told their stories publicly. They lived out their lives in obscurity, in institutions or in family care, their experiences unrecorded and largely unacknowledged. The full human cost of lobotomy will never be completely calculated, because so many of those who paid that cost did so in silence, their suffering noted only in hospital records that few people will ever read. The question of responsibility, of who should be held accountable for what happened during the lobotomy era, has no simple answer. Walter Freeman died believing he had helped people, that his work had been valuable, that history would vindicate him. He was wrong, but his self-deception was probably genuine. James Watts expressed some regrets later in life, acknowledged that transorbital lobotomy had been a mistake, but defended the earlier work he and Freeman had done together. António Egas Moniz died in 1955, before the full extent of lobotomy's failure had become apparent. Whether he would have acknowledged error if he had lived longer is unknowable. The Nobel Prize awarded to him in 1949 has never been revoked, despite periodic calls for the Nobel Committee to rescind it. The committee's position is that Nobel Prizes are never revoked, that they reflect the understanding and values of the time when they were awarded, not later revisions of history. The hospitals that performed lobotomies, the physicians who operated, the families who consented, all these acted within the medical and social norms of their time. This does not excuse what happened, but it complicates simple narratives of individual villainy. The lobotomy era represents a systemic failure, a collective abandonment of scientific rigor and ethical restraint, a willingness to embrace dramatic intervention in the absence of adequate evidence, because the alternative seemed to be giving up entirely. We look back at lobotomy from the vantage point of modern psychiatric care. With its emphasis on patient autonomy, its requirement for informed consent, its arsenal of medications that can manage symptoms without destroying brains. It is easy from this position to condemn the past, to wonder how anyone could have thought lobotomy was acceptable, to see the errors as obvious. But the people of the 1940s did not have our perspective. They faced genuinely desperate situations in psychiatric hospitals. They watched people suffer for years and decades without improvement. They had no effective treatments to offer. When lobotomy appeared, promising relief, many embraced it not from cruelty, but from hope, from the desire to do something rather than nothing, from the belief that action was better than paralysis. The tragedy is that the action they chose was so destructive, and that the mechanisms that should have identified this, careful research, rigorous evaluation, honest acknowledgement of failures, did not function as they should have. The tragedy is that economic incentives and professional ambition were allowed to override patient welfare. The tragedy is that tens of thousands of people had their brains irreversibly damaged in the name of treatment before the medical profession recognized what it was doing. Tonight, in the silence of these late hours, we have descended into dark territory. We have examined a history that makes us uncomfortable, that forces us to confront difficult truths about medicine, about society, about ourselves. The story of lobotomy is not a story of evil people doing evil things. It is more disturbing than that. It is a story of well-intentioned people working within systems and institutions, making decisions that seemed reasonable at the time, but whose consequences were devastating. This history matters not just as a memorial to those who suffered, though that alone would justify remembering it. It matters because the conditions that allowed lobotomy to flourish, the desperation, the willingness to embrace dramatic interventions without adequate evidence, the prioritization of institutional needs over individual welfare, these conditions did not disappear when lobotomy ended. They persist in different forms, in different contexts, waiting for the next time medicine offers something that promises too much and delivers too little. The cost of progress in medicine is sometimes paid by those who undergo treatments later recognized as harmful. The people who were lobotomized paid that cost. They did not volunteer for it, Most did not consent to it in any meaningful sense. They were subjected to it by others, and they bore the consequences for the rest of their lives. We remember them, we honor their unwitting sacrifice, and we commit to learning the lessons their suffering should teach us. Before we part, know that this history is documented, studied, remembered. Those interested in understanding more deeply can find extensive resources on the history of psychiatry, on medical ethics, on the evolution of mental health treatment. But perhaps the most important thing we can take from this exploration is vigilance. Vigilance against the next promised miracle cure. Vigilance against medical enthusiasm that outpaces evidence. Vigilance in protecting those who cannot protect themselves. In remembering those silenced by lobotomy, we ensure that their voices, lost as they were, still echo forward, still warn us, still matter.